All right, so I'm Yap. Thanks for letting me present today. I guess a little bit about me is that I love psychopharmacology, as you're gonna see in a second. I want to be a space psychiatrist. You might be wondering what that means, but it's basically helping astronauts deal with the psychological stresses of space flight. That's a little bit of a side interest of mine. I unfortunately have a TikTok. It's at YapMat, my first name followed by MAT. And I also edit Wikipedia. So if you've looked up drug names, especially psychoactive drugs, I might have had a hand in what you read because I just like to do that in my free time. The objective of this presentation is to get you interested in pharmacology, psychopharmacology first and foremost. So while it's titled a presentation about a specific drug, I feel like that's actually a very good way to get people excited about or learn about pharmacology is using specific individual drugs as case studies. But what I discuss here is more generalizable to the vibe of pharmacology. So if you find what I say about Zolpidem to be interesting, then I'm sure you're going to love the rest of what Wikipedia and other resources have to offer. So definitely take a look on your own time. But to just give a general kind of get people excited, in the first 5 minutes, I'm going to blitz through a few facts about psychopharmacology and that just to keen the interest and show you how wide and exciting this field is. And if you are 1/10 as excited as I am, then I will have done a good job. All right, so this is taken directly from a video of mine on interesting facts in psychopharmacology. I guess the first one here is that there's a drug that can make you lucid dream. Up to 50% of people who took this drug were able to lucid dream. It's a drug used for Alzheimer's, I believe, and it affects the acetylcholine system in the brain, if you're familiar with that. Another one is that the long-term use of psychedelic drugs is associated with differences in brain structure. This was a relatively new study showing that there was an atrophy of the posterior cingulate cortex, which is more so implicated in the default mode network of the brain, essentially introspective or self-thought, brain wandering, mind wandering seems to be correlated with activity in this network. Obviously, that's not what this finding is showing. It's just showing an atrophy and then a growth in another region. And that's not necessarily a bad thing. In fact, that might explain why some people seem to think that after psychedelic usage, they are more in the moment and present. But it is a very interesting finding that a drug, limited exposure to a drug, can actually fundamentally change morphological structures in the brain or associated with it. Sorry, this is not a causative study. Another one is LSD on the molecular level being trapped in the human 5-HT2A receptor. 5-HT2A is a receptor for serotonin that is the main psychotomimetic receptor for most psychedelics. Now, this is trapped is in quotation marks because it does eventually unbind, but this helps explain potentially why the effects of LSD persist long beyond what would be predicted by its half-life. It only has a half-life of about 3 hours, I believe, similar to psilocin, which is the active drug that is produced from psilocybin, yet it lasts a lot longer in its effects. And it's possible that this sort of manhole cover that is created by the amino acid residue could be keeping it in the receptor for longer and effectively prolonging its duration of action. Here's another one. Phenelzine is an MAOI, and it completely abolishes REM sleep in the first few weeks of using it. And there seems to be no negative effects on cognitive function in those patients while they're in the state. So yeah, it's interesting that a drug can completely abolish a stage of sleep that for a very long time we thought was actually strictly necessary. Although this is not to imply that REM sleep is good or bad, it's just an interesting finding. And then also, for those of you who might work out and such, there's a study showing that a single 20-gram dose of creatine improves cognitive performance during sleep deprivation. And that's a single dose, not constantly taking it. So yeah, that's just, I guess, a general outline of the things that you can find or expect to find in psychopharmacology. And it's very wide and wide in general field, but I find it very interesting, as you can see. And if you're more interested in these types of little factoids, I have some more on my TikTok. All right, getting on to the main part of the presentation. I want to talk about Ambien, or Zolpidem. Ambien is, I think, a United States brand name. It might not be referred to that as that elsewhere. But it has a bit of a popular conception, at least in American culture, from back in the 2010s, less so now. Um, there was an idea that based on a very rare side effect of the drug, which is hallucinations and delirious thought patterns, that this was more common than it actually was. And because of this, there's some jokes like the Ambien walrus on the left here, and in one case there was actually a very funny exchange in which the pharmaceutical company that markets Zolpidem in the United States replied to someone who was also a celebrity, claiming that they made a racist or insensitive tweet because they were under the influence of the drug. And the pharmaceutical company replied saying that racism is not a known side effect of that medication. So that's a bit of a funny exchange. The effects of Zolpidem, though, are less sensational than those previous pictures would suggest. This is taken from Psychopharmacology. Of course, that's not a super objective look at the effects of a medication, but it does describe certain effects that are less touched on in clinical trials. I only chose to feature stuff that is reflected in case reports and just general clinical experience with the drug. So the physical effects, obviously, number one is going to be sedation. That's part of the mechanism of the drug, is to sedate someone so that they can fall asleep. Appetite enhancement is also another effect that is experienced by some. There's some cases of people eating at night, both because of the amnesic effect and the disinhibiting effect, and also the appetite enhancement. But again, this is a bit rare. Muscle relaxation is a very interesting point that I'll touch on later. It's present, but it's a lot weaker than that of benzodiazepines, which is a very significant action that plays into Zolpidem's pharmacology. Again, another thing about the comparison to benzodiazepines, there's less muscle relaxation. The cognitive effects, amnesia is a common effect. About 20%, if I remember correctly, 10 to 20% of patients will have some sort of amnesia and tardigrade after they take the drug. So it can be difficult to remember things that you did after you took the drug. Usually people are intended to take it before they fall asleep, so it's not that big of a deal. But if someone was to perform or stay up and perform actions after the fact, they might not remember that the next day. Anxiety suppression, also significantly weaker than that of benzodiazepines, which again we'll touch on later. Cognitive euphoria, that effect, there is a mood lift effect at therapeutic doses, but it's not extremely strong, but it does lend itself to the abuse potential of this drug. Again, just to keep people interested, yes, at very high doses, the drug does produce certain visual alterations and visual effects. Occasionally, this can occur at therapeutic doses in certain populations. There's evidence that SSRIs, like Prozac, can increase the risk of this occurring through some sort of unknown interaction with the medication. Usually, these pictures here are not super representative. I would say the one on the right seems to be more representative of what is described in certain case reports and unofficially by people. But it's this sort of rippling effect that is perhaps a little bit reminiscent of psychedelic drugs. But again, there's not too much information on this, but it is a little interesting fact that at high doses or in vulnerable populations, this can occur. Getting back to the clinical side of things, Zolpidem is the 63rd most prescribed drug in the United States. We do love our sleeping medications and short-term fixes. There are 2.5 million patients that were taking it at the time. And it's approved for the short-term treatment of insomnia, although it might not always be used for that. There is care that is usually taken to restrict its use to less than a month to avoid withdrawal syndromes and dependency. It's also used occupationally by the U.S. Air Force. It's officially designated as a no-go pill, meaning that after a pilot takes it, they cannot operate an aircraft for about 6 hours afterwards. And the official designation is for the management of fatigue and circadian rhythm problems, especially when they travel across time zones. It was also the most used medication on the space shuttle back when it was in commission. The majority of astronauts took it for the majority of nights. It was one of the three medications used for sleep on the space shuttle, but it was by far most likely the most used medication because it's the most popular of those three drugs. On the ISS, it's a bit of a different story. It seems that on the ISS, when astronauts go first up into space, sleep is a bigger issue than it is once they become habituated. So it is the most popular medication used during acute phases, but over prolonged periods, it no longer becomes the most used medication. But it is interesting that it is one of the most dispensed medications on the International Space Station, and it's understandable. I mean, astronauts definitely struggle a lot with sleep and circadian irregularities, so it is indicated in that population. All right, Zolpidem belongs to a class of drugs called the Z drugs. They're creatively named. I think it was a cool little exercise that all the scientists got together and then named them with a Z or a Z. The differences between the Z drugs is predominantly in their duration of action. So the Zaloplon has a half-life of 1 hour. It's the shortest acting one. Zolpidem is in between, has a half-life about 3 hours. And Zopiclone, or its enantiomer as Zopiclone in the United States, has a half-life about 5 hours. So they expectedly can either initiate sleep or maintain sleep with different risks of next-day impairment. Zolpidem is kind of in between, though, and it seems that this property has made it the most popular Z drug in the United States. So the Z drugs were developed to replace benzodiazepines for insomnia. Some of the benzodiazepines that you might know of are Valium and Xanax. The benzodiazepines worked quite well for insomnia, but they had issues, one of which was dependency and withdrawal. Withdrawal itself could produce seizures and was just generally unpleasant and could be protracted. They are technically non-benzodiazepine, that this refers only to their chemical structure. They don't contain the fused ring structure that would qualify them as a benzodiazepine, but they do still interact with the benzodiazepine subsite, the benzodiazepine site on GABA-A receptors. The GABA-A receptor is a very popular receptor for many different psychoactive drugs. You might recognize that on this little graph here, figure here, you have ethanol has a binding site on there. Same thing with general anesthetics, benzodiazepines, like we discussed, barbiturates. And if you've watched The Wolf of Wall Street, you might know what methaqualone or Quaalude is. It also has a binding site on this GABA-A receptor. And you might be wondering why did it replace benzodiazepines if it effectively binds to the same receptor sites on these complexes? Would it not have the exact same effects? And the distinction here is that actually based on the general makeup, so this receptor is made up of different complexes, based on different subunits. Based on the subunit makeup of that receptor, this can influence what it's involved in and what effects it's involved in. So the ones that contain the alpha-1 subunit are most involved in the sedative, anticonvulsive, amnesic, and addictive effects, whereas the ones with the alpha-2 are anxiolytic and muscle relaxing and things like that. So the idea was if we could develop a drug that targeted the sedative one and not the anxiolytic one, we could create a drug that was more selective for sleep without so many off side effects that weren't relevant to that. And that's exactly what the Z drugs do, is they're selective, at least in theory. Some of them are not, Zopiclone in particular, but Zolpidem is very selective for the alpha-1 containing one, which makes it so that it has more sedative and anticonvulsant effects rather than anxiolytic ones. Now, unfortunately, the alpha-1 receptor makes up 60% of GABA-A subunits, GABA-A receptors in the brain. So specifically targeting the alpha-1 doesn't really offer very much in the way of selectivity. Um, as I stated before, you're only really getting rid of the anxiolytic and muscle relaxing effect. You still retain the amnesic and addictive effects of it, which is unfortunate. But it does at least get rid of some of the unwanted effects that might not be relevant to insomnia. You might be wondering though, why is it that we don't have the alpha-2 selective benzodiazepines? If you looked at the graph here, you'd think that an alpha-2 selective benzodiazepine would be very useful. In fact, probably more useful than alpha-1 selective benzodiazepine agonist, just in the fact that it would avoid the addictive potential while retaining the anxiolytic effect. But it just so happened that we did have one on the market. It was actually an analog of Zolpidem called Alpidem, but it was discovered to be hepatotoxic. It caused liver failure in a handful of patients, and it had to be taken off the market. And that's just a general theme in psychopharmacology, is that the liver doesn't really play well with a lot of innovative drugs, and can sometimes be the reason that we have something get taken off the market, even if it was a very good psychotropic drug. So Zolpidem's clinical effects are different than benzodiazepines. It seems that by specifically targeting the alpha-1 containing GABA receptor, its effects on sleep architecture are a lot less disruptive than those of benzodiazepines. The benzodiazepines used to prolong the deep sleep to a minor extent, but they would also increase the amount of light sleep and then also decrease the amount of REM or dreaming state of sleep where the majority of dreams occur. Whereas Zolpidem has minimal effects on sleep architecture, and even abrupt discontinuation after a few weeks of use does not cause a rebound in REM sleep like it does with benzodiazepines. And just to articulate what I'm talking about here, this is what normal human sleep architecture looks like. First, you have a deep sleep, and then you have a REM sleep, and then over the course of the night, the REM sleep gets longer. A benzodiazepine would suppress that REM sleep. And then when you withdraw off the benzodiazepine, the REM sleep would come back, maybe 2 times stronger than it is normally, and that can disrupt sleep quality, both when you're on the drug and when you're off the drug. Okay, revisiting Zolpidem's side effects, there is the hyperphagia effect that can occur in some people. It might be tied to disinhibiting effect of the drug. There are stories of people having emptied their fridge because of the disinhibiting effects of the drug. This seems to be a little bit more common, although still infrequent, relative to the hallucinogenic or delusional effects of the drug. Those seem to only really happen in a very small minority of patients. But it is something to note because it is still targeting fundamentally a receptor that other disinhibiting drugs are known to affect. There's also when Zolpidem was first introduced, there was a lot of enthusiasm and hype behind it. We had finally discovered a benzodiazepine that did not cause, or benzodiazepine agonist that did not cause withdrawal and sleep architecture impairment. But then once we started to study these more, there was a lot of doubt cast on these claims. One of which is that Zolpidem, there's a relationship between Zolpidem and cancer risk. It seems like the benzodiazepine receptors generally affect also the immune system, so much so that benzodiazepines do have a correlation with skin cancer, and that might be due to a suppression of immunosurveillance. And then also benzodiazepines can coax microglia to prune synapses. They might increase the rate at which synapses are broken down, and that might translate to long-term memory impairment, which might connect to the risk that we see with dementia in patients who are on benzodiazepines long-term. Again, nobody knows if this is because people who take these drugs also have other health problems or if it's the drugs themselves. But it is still a bit of a worrying correlation that has driven down their use and prescription rates. Okay, this is probably by far the most interesting side effect of Zolpidem. What you're looking at here is a minimally conscious patient. So they are this on the top two lines here. It's indicating areas with abnormal abnormal glucose utilization. And you can see that the prefrontal cortex has a lot of abnormal utilization, and same thing with the thalamus. But then once they are given Zolpidem, it seems that specifically in the prefrontal cortex, there's a restoration of glucose metabolism. And this actually translates, at least in a subset of patients with traumatic brain injuries or who are in vegetative states for other reasons, a temporary restoration of cognitive function. So this is the patients. Right. They're not able to use the comb, and when they are, it's in a very indeliberate fashion. But once they're given the Zolpidem, there's a remarkable change in a matter of minutes.
I'm gonna give you this comb. Show me how we use it. What do you do with that comb? Nice job, you got it. Perfect. I'll take it back. Thank you.
And this was actually serendipitously discovered by a mother who accidentally gave her child who was in a vegetative state Zolpidem instead of their intended medication, and it woke them up for a few hours. Unfortunately, the effect of the medication is temporary. Once the medication wears off, they go back to a vegetative state. But there is evidence to suggest that tolerance to this effect does not occur, provided that it's used only once or twice a day. So very interesting that it can provide a glimmer of hope and allow families to communicate with vegetative family members while they're recovering.